So just to start off with, and this is clearly focusing on this high-risk group, which we're going to be talking on for TAVI therapy later. So just start off with, I'm afraid, a little bit of boring statistical introduction. I just want to make sure everyone's clear about some of the words I'm going to be using. So prediction mortality is a form of binary classification, and the performance of which can be measured by the specificity, the proportion of patients that survived, the true negatives of all those that survived, or the sensitivity, which is the proportion of predicted deaths of all those that have died. One of the easiest ways of looking at these is with a receiver operating characteristic curve, a ROC curve, and this is a graphical plot of sensitivity versus the false positive rate. So it's sensitivity versus 1 minus the specificity, and therefore we can calculate the C statistic by integrating the graph to get the area under the curve. And this informs us only of the probability that the model will rank a randomly chosen positive event higher than a randomly chosen negative event. So it's the same as a sort of a Wilcoxon rank similar Mann-Whitney U test. For a more detailed information, what we really want to look is the goodness of fit of the model, which is where you use the Hosmer-Lemeshow test. And this assesses whether or not the observed event rate matches the expected event rate in subgroups of the model population, and specifically identifies subgroups as deciles of fitted risk. And models for which the expected and observed event rates in subgroups are similar are called well-calibrated models. So I just want to talk about the problems with the risk modelling that we have in patients who are perceived to be at high risk for surgery. Well, first of all, we know that patients with high risk who undergo surgery may often have risk profiles in whom data is not routinely collected. So patients may have significant immunosuppression, may have undergone radiotherapy, they may be very frail, may have issues with malnutrition. Then we have problems in predicting high-risk patients and variables that are representing subgroups of whom the patients are completely absent from the data set in whom the model was created. And of course, all models are created on a subset of patients who have undergone traditional surgery, and therefore high-risk patients with things like liver failure or home oxygen will not be represented in any risk stratification model. It's difficult to predict how these high-risk patients will do from conventional surgery. Then we also have variables in whom the predictive power has been lost. So we have things like continuous data that's been medically categorized for convenience. So things like renal function, so rather than have linear glomerular filtration rates, we have arbitrary definitions of chronic kidney disease or of creatinine. So when we look at some of the data about prediction of high-risk patients, on the first page I'd like to look at is from this paper by Dr. Gomiccio, which is an analysis of almost 380 patients undergoing isolated aortic valve replacement over 10 years. And they looked at 2 5-year periods and looked at the performance of the Euroscore pre and post this. And the interesting thing from this paper was the fact that although the model fit for the total cohort wasn't very good, in the first 5 years we can see that the model actually worked quite well. And it's only in the more contemporary 5 years that we have lost model fit, and you can see that the C statistic for patients undergoing isolated aortic valve was over 0.7, which is the C statistic which we commonly accept to be useful, and in contemporary data it's now dropped down to 0.5. So then we look at one of the seminal papers from Dr. Mack's group by Todd Dewey, which looked at the reliability of a number of risk algorithms in predicting early and late outcomes in high-risk patients undergoing a surgical aortic valve replacement. And what they did was they calculated the STS predicted risk of operative mortality, the logistic Euroscore, the additive Euroscore, and the ambular risk score. And what we can see from these is the risk scores really do quite poorly throughout all these models, although the STS score performed the best, with an observed to expected perioperative mortality of ratio of 1.4. So again, the other interesting thing about looking at these models is all these models were unique in that they identified different patients as being at high risk. So it wasn't that we had the logistic Euroscore and the STS score both identifying the same patient cohorts as being at high risk. Each model actually identified different types of patients as being at high risk for undergoing conventional surgery. And as I said, so when we looked at the observed versus the predicted mortality in this paper from Dr. Mack, the STS score predicted mortality of 13.3% for an observed mortality of 18.1%. But the logistic Euro score, as you can see, was massively out. The additive Euro score was significantly out, and as was the Ambler score. And then we looked at some of the data from Dr. Cohen's group, and again we can see similar issues, even when it's gone down to minimally invasive viewpoints, is that the Euro score really is failing to predict adequately these high-risk patients. So when we look at the ranked performance of scores for high-risk patients undergoing coronary surgery, the STS score is still felt to be a valid score. That's clearly a procedure-specific model, but the European-based scoring system seems to be failing us in this respect. So the thing I'd like just to mention very briefly is some work that Ben Bridgewater and Domenico Bogano have done on behalf of the Society, which is generating a new risk model, which presented some preliminary work last year, but this has now gone into full swing. It's got past some of the political difficulties that we had and is now going to be up and running, hosted and published in this month's European Journal of Cardiothoracic Surgery. So we looked at all patients in the STS adult cardiac surgery database who'd undergone conventional aortic valve replacement with or without CABG from 2001 to 2008, and then we validated it on a further cohort of patients subsequent to that. We did a lot of analysis with candidate variables, and we addressed missing data through a specific missing data unit we have in Birmingham to build the model. So what we ended up with this model that we have is we actually ended up with a slightly better score than even the STS score based on a European data set of scores. So we ended up with a C statistic for this model of 0.79 compared to the logistic Euro score of 0.59, additive of 0.64, and Ambler of 0.66. Interestingly, when we've recently redone this analysis on the recently produced Euro score 2, we can actually see the Euro score 2 actually performs worse than the additional Euro score on this set of aortic valve replacements. So certainly, I think when we're considering high-risk patients for consideration of surgical aortic valve replacement, the Euro score 2 would seem to be a retrospective step in terms of risk prediction for this group of patients. We couldn't specifically compare the model to the Society's data on the validation data set for this period of time because they clearly use different data sets, and that's clearly the drive for us to try and produce a European-derived data set that we can use for these patients. And as you can see, the main issue for us in the model we produced for the Society is in the highest risk centile. So this is a group of over 1,000 patients in whom we have observed 249 deaths. So we're talking about a patient group with a observed mortality of almost 25%. We can see we predicted 251 deaths, so we're pretty much spot on the money there with a 25% predicted mortality for that group of patients. And again, if we compare how our current model would do compared to the Mike Mack paper with Todd Dewey, we can see that our current model would predict an operative mortality of 15.3% versus an observed mortality of 15.7%. So again, a one-to-one ratio of a predicted risk of mortality in this high-risk group of patients. Now, clearly, there's a number of variables that we know predict outcome, which are currently unavailable for risk construction, and the model is specifically designed for risk prediction aortic valve surgery, and its use has neither been applied nor validated in patients undergoing TAVI, although clearly we have work in this field already ongoing. So in conclusion, we've developed a model with a good fit to contemporary data. The model performs well across the whole spectrum of risk, including the highest decile of risk, and this model may be of use in supporting decision-making for patients at high risk of conventional aortic valve replacement. As I said, it's going to be published this month in European Journal of Cardiothoracic and Cardiovascular Surgery, and a web-based calculator will be available and hosted by Birmingham University. Thank you very much for your attention.
Thanks very much, Neil. Can you give us a preview then? Can you tell us what's in it that's different from Euroscore?
So the data set is based upon the data we collect within the Society Blue Book. So a lot of the variables are the same. The real difference, I think, to it is that it's a procedure-specific model. It takes into account the whole spectrum of aortic valve disease. So this is a risk calculated for patients with severe aortic regurgitation and impaired left ventricular function with active endocarditis, as well as degenerative aortic stenosis. So it's specific to the procedure. And also we spent a long time looking at various interaction terms, because we know as surgeons, we know as statisticians, that there's a hell of a difference between a patient undergoing an aortic valve replacement with a good ventricle who requires a incidental single bypass grafting to a patient with an impaired, very hypertrophied, failing ventricle with severe triple vessel disease. And one of the main things we've found about the predictive power of this model is looking at the specific interactions between the extent of coronary artery disease, the pathology of the aortic valve, and the function of the left ventricle. And those three interact very clearly together, and we think that's really the main difference that's given this model the improved predictive power.
Is it usable as easily as STS or Euroscore in terms of do you have maybe some kind of online system where you put in data and get the predicted mortality?
Absolutely. So it's going to be very similar to Euroscore in terms of size of the field. So I mean, clearly the STS is a very good calculator, but it's very cumbersome to use and it requires a lot of information. This is information that we are already collecting as a society for the Blue Book returns. So it's data which we are familiar with, it's data we're already collecting. It will be something very easy to use, yes. We also have data fields for if people are retrospectively doing things or for audit purposes that if you generally don't know, you can put in you don't know the data, and that also has a different statistical analysis on this as well.
Is it your impression or knowledge that if you take out, you mentioned in your score that you do ABR plus minus cabbage, if you just take out the cabbage, does the predictability go up even more? I mean, is it really, if cabbage is out of the equation, what happens to the prediction there?
No, the predictability with the AVR alone is equivalent to the predictability with patients with cabbage. Yes, that's fine.
Can I just raise 2 points, Neil? Partly because this is the TAVI session.
Of course.
But I mean, when you say it applies across the board to aortic valve disease, it does it in the sense because you've not taken the patients who have not come for surgery.
Absolutely.
And I think that's an important point. The other thing that when we talk about patients going forward to TAVI is not so much their mortality, but more their risk and their morbidity post-operatively. And how far are we or anybody, sort of helping us sort of talk about morbidity to patients and then risk stratifying morbidity nowadays?
I think my understanding is there's quite a lot of prospective work going on with that, but clearly to devise models to do that, we work on the basis we probably need about 10,000 patients to produce a valid model. So unless we have the data already collected on the morbidity outcomes on those patients, it becomes more difficult, but that is certainly a work in progress at the moment.
Good. Thank you very much.
Thank you.